turn this over to Jonathan. Go ahead and take it away.
All right. Thank you very much, Becky. It's great to be here. Again, sorry everybody for a little delay in getting started. I will just say a little bit to start with about the TRCs and who we are. I imagine most of you who are on this call know who we are, but we are made up of 12 regional TRCs. UMTRC is one. There are others all across the country. You can see them there in the different colors, and we provide technical assistance to organizations of all kinds trying to start and sustain and maintain and grow telemedicine programs. We provide a lot of resources, which you can reach at our common website at telehealthresourcecenters.org. And from that site, that national site, you can reach all 14 of us. I just want to shout out to the National Policy Center, the Center for Connected Health Policy, and the National Telehealth Technology Assessment Center. Those two TRCs do deep dives on policy and technology, respectively, and you can get a lot of information there as well. We also can provide contacts to other programs and lots of other information. So get in touch with us. You're obviously, of course, welcome to browse our websites and read as much as you want, but it's a lot easier and quicker usually to just contact us directly and ask questions and let us help you find what you need. So I'm going to talk about telehealth kind of from a conceptual level today, just because I find level setting and getting a conceptual framework is often the first thing I need to do in working with organizations. If for some of you this may be repeat, for some of you it may be new, and hopefully it stimulates some thought for everybody. But the issue that we find a lot of times with the TRCs when we talk to organizations, groups of people, heterogeneous groups of people, you never know where somebody's at in the process, what exactly somebody's trying to accomplish with telehealth, and telehealth is lots of things. And so as soon as we start digging in specifically to certain issues or certain aspects of telehealth, the deeper you get into a program, the narrower the focus is. And so whenever you have a group of people and you're talking about telehealth, as soon as you start getting into detail, you lose some of them because those details don't apply to them, whether it's because they're in a different state than this and the Medicaid policy is different, or because they're doing a different type of telehealth, they're trying to reach these patients instead of those patients, they're using a different technology platform, or they're doing store and forward instead of live video, et cetera, et cetera. There's just so many different aspects of telehealth that we struggle with this question of whether to talk in generalities that apply to everybody, but most of us have heard before, or to dig down more specific into details and risk losing people for whom those details don't apply. So I'm going to try and strike a balance, and the overall message is, and I'll say this again multiple times, get in touch with us, let us know what you're doing, and let us know how we can answer the questions that you specifically have, because that's the way we can best be of help to you. I'm going to give it some conceptual framework comments, and then talk about integrated behavioral health and this concept of referring out versus contracting in, just as a way of framing some questions. I'll say a little bit about collaborative care, which is coming down the pike, and it's going to be big at some point. But we're still, Medicaid is still sort of a hit or miss proposition, although Medicare is on board with that. And then we might have some time at the end for some questions and answers. So first of all, I want to make a comment that I make to almost everywhere, and that is my opening line about telehealth is not one thing anymore. There are at least 4 domains that we can talk about telehealth within, and that includes hospitals and specialty care, so whether that's tele-ICU or various telespecialties, telecardiology, neurology, psychiatry, whatever, specialty care. And we're talking about it from the perspective of the provider, from the specialist to the place, to the patient, to the area of need, to the clinic. If we flip that around, we get the second domain, which is integrated primary care, where we're talking about we have the patients with needs and we're bringing in specialty care of various kinds, often mental health. Often folks are bringing mental health into primary care, but we're talking about bringing specialties into a primary care setting to see patients. It's a similar process from one side or the other. technically, but the motivations and the contingencies around it look different depending on which side of the window you're looking through. Remote monitoring and transitions is, of course, something that's an ongoing domain of telehealth, but it's very, very different than doing live video encounter-based services. And then direct-to-consumer, which has come on like gangbusters in the last couple of years, is, again, using similar technologies and similar idea of reaching people, but a completely different business model, a completely different strategy, different entry point. It's a significantly different practice overall, even though it's still in this world of telehealth. And so people sometimes are referring to that when they're talking about telehealth. Telemedicine is a delivery mechanism, not a service. I make this point a lot. And the reason is because when you're a provider who's providing services, like I'm a clinical psychologist licensed in Indiana, I don't need any new credentials or new, it's not a specialty or a subspecialty. If one's a physician or a nurse practitioner, telehealth is not a subspecialty that requires any new credentials, but it is a different context that you're working in, like working in an Army field hospital versus an academic medical center. A kidney is still a kidney, and if you're doing surgery or you're taking a temperature or whatever, it's a similar skill set, but the contextual factors differ, and you need to be aware of those in order to be an effective clinician in those settings. So when we talk about the regulatory environment, the settings within which telehealth happens at the federal level, really the only laws that say what you can or can't do are healthcare and privacy regs in general, like Stark and anti-kickback and HIPAA, and then prescribing controlled substances, which is talked about a little in the Ryan Haight Act. And I won't dig into that too deeply. Follow up with questions if you have questions. Ryan Haight limits how you can prescribe controlled substances. It has a telehealth clause in there that's a little bit problematic because it's kind of left unfinished. It's kind of hanging up in the air. But what you can and can't do, there's not a whole lot at the federal level. Now, what you can and can't get paid for at the federal level is covered in Medicare regulations, and they are significant. But they're not saying what you can or can't do. They're saying what you can or can't get paid for, and that's a significantly different issue. At the state level is where most of the rules about what you can and can't do are covered, and they're covered in state licensing boards. Now, there are also some healthcare regs that will sometimes define, what kind of practice falls under which domain, whether it's mental health or separate mental health regs, or whether telehealth is defined in a certain way. But the licensing boards are really where most of the regulation of what you actually can or can't do in telehealth are accomplished. And this is why providers are always kind of the ones that are kind of the tip of the spear here when we're talking about telehealth programs and feeling at risk, because it's their license ultimately that's on the line. Now, Medicaid, of course, has the same kind of conditions of payment, commercial payers as well at the state level. When we're talking about security and privacy as a concept in telehealth, we take as an assumption, and certainly it's something that we all have to just sort of make part of the cost of doing business. The video counters are always encrypted. They're almost never recorded, although patients often ask, and they're wondering if when you consent them, when you provide them information, they're wondering about recordings. It's one of the top things on patients' minds, but we need to make sure and tell them we don't record telehealth sessions unless we get a separate consent, and there's some process in place to do that, just like in regular healthcare. Another sort of privacy and security issue is when we're using patient equipment, like into the home. If you're doing telehealth into the home and you're relying on the patient's cell phone or the patient's computer or the patient's internet connection or whatever, it's possible to do that, but it's challenging because for a couple of reasons. Number one is, of course, the quality of that infrastructure you're going to rely on, and connecting that infrastructure with your own infrastructure over a networking connection. But also the patient's email address or their IP address or their URL, those are all potentially PHI, and they have to be treated as such in the encounter. And if we're using a web-based platform like today, what we're doing, we need to be sure that we have a BAA and an agreement with with the companies to ensure that they are obligated to provide the level of security that we need to do a medical grade, a healthcare grade encounter. Most of the big, almost I should say all of the reputable video conferencing vendors will provide that now, and they'll at least attest to that level of security. So, so you need to be sure that you have that. One workaround that people do is they will send their own equipment out using their own connection through either a virtual private network or some other secured connection, so that if a home health worker or somebody is taking a laptop into the patient's home, opening up and having the patient see the provider that way, or however that works, whether they're handing out cell phones or handing out tablets or whatever, that's another way to make sure that as a provider, you're ensuring the privacy of that connection. Telehealth and EHRs comes up a lot as a question, and folks ask me a lot, should we be working toward an integrated telehealth solution within our EHR? And the point I want to make about this is that these sorts of products and features exist on a continuum, and the integrated end of the continuum is not necessarily the best end for everybody. Now, if you're in a large health system and you've got an EHR, a big EHR, big hospital EHR, or even primary care EHR that provides, integrated telehealth services, basically it's a live video function and a start, stop, and scheduling, and all of that's integrated to a telehealth feature. If you've got that, then great, that's fantastic, you can use that. If you don't have that, you can generally accomplish the exact same thing with a separate live video component and whatever EHR you're already using. That's on the disintegrated or unintegrated side of the spectrum. And the reason that I bring this up is just because organizations are trying to think, should we be moving in that direction or towards full integration? And the fact is, there are lots of challenges and costs associated with that, and it's not entirely true that you get more with a fully integrated solution. At least depending on the size of your organization and the complexity of your program, it's not entirely true that it's not necessarily true that you're going to, that kind of a service is going to function better for you or accomplish what you need more effectively. In the middle, there are a number of applications out there that are basically video plus a lightweight EHR to provide that are really targeted kind of independent clinicians or providers, private practice providers who need to do live video with a patient and also collect a little bit of information about those patients. And so there are a number of products out there, but many of them really, like I say, are targeted at the private practice, small clinic, individual provider, small office sort of environment, and aren't really suitable for a medical clinic or a large health system. And so if you recognize that continuum from separate systems to integrated light systems to fully integrated EHRs, and you see that the products that you're looking at may fall anywhere on that spectrum, and it doesn't necessarily mean that they can or can't accomplish a certain feature that you need. And so it's important to recognize that continuum of products out there. Documentation is, of course, something you need to be thinking about. You, at a minimum, need, of course, to have policies and procedures in place that reflect the fact that you're using telehealth. We recommend, though, that when you're thinking about implementing a program, that you think about it as using, to a large extent, if you're doing on-site healthcare and we're sort of integrating a virtual behavioral health component or a telebehavioral health or some other sort of teleservice, telecardiology, whatever, we recommend that you try and follow as much as possible the same procedures in the sense that the patient's going to check in at the front desk, that someone's going to bring the patient back to a room. The provider, instead of walking into the room with a chart in hand or logging into a computer there in the room with the patient, is going to be coming in virtually by a screen on the wall, logged in remotely to the EHR and seeing the patient virtually. But then when the when the encounter is over, the patient's going to be walking out to a checkout desk and checking out and scheduling a follow-up and taking care of copays and whatever. And that process, that workflow, is largely the same regardless of whether the provider is virtual or on site. Now, for some services, that's just not going to work. You're talking about a differently conceptualized service, and this is where we're kind of getting into weeds that won't apply to one group versus another. But the basic principle is, if you have an existing workflow and you can mirror that workflow with your virtual component, you do that. And if you can't, then you figure out a workflow that works for your virtual component. And it's fairly straightforward. Another thing to keep in mind is that is what source of patients you're allowing into the telehealth program, because they, in most programs, are going to be alone with a provider who's there virtually. And so you don't want patients who are at high risk, or who, children who can't be unsupervised or whatever. I mean, there are a number of times, at least in the mental health world, where we're concerned about, or corrections world or some other, where we're concerned about the behavior of the patient or the equipment in the room by themselves. And so we just need to be aware of that. And do we screen patients in a certain way so that we only get certain patients in the room? Related to that, there always has to be an emergency back channel, kind of a hotline, so the remote provider can say, can call a number, and somebody on site in the clinic, just outside, not necessarily waiting outside the door, but within range, so that they can quickly run to the room and run in and intervene in the case that the patient is choking or passed out or has some sort of panic attack, or some sort of adverse event is happening. Even something as simple as, the video broke down and we need someone to come in and discontinue the session and escort the patient out. You just need a way for the provider to do that. We also want to document, and so if there are emergency issues that come up, the provider needs to have a way to contact local on-site folks. And if it's not a site, if they're seeing the patient at home, they need to be able to locate and contact emergency services for the patient at their location. If the provider picks up the phone and dials 911, they're going to get their own local emergency services, but not necessarily the patient's. And so you need non-911 contacts if you're seeing a patient outside of a clinic setting, or in some place where you may need to contact emergency personnel for help. Obviously, it doesn't happen very often, but it's just one of those things that the time that it happens and you're not ready for it is the time that's going to count. There are informed consent issues that one needs to take care of. We need to document that. Document start and stop times, because it may be important, not only how long the session was, but at what point did something happen? Did it happen during the session or after or before? And so you need more or less precise start and stop times. And then the locations of the provider and patient. Sometimes on audit, that's something that auditors need for validating that the encounter met criteria for payment. Certainly Medicare needs that. And then any ancillary providers or personnel that were involved, just so that encounter is fully documented for auditing purposes, if it comes to that. Another thing that we talk about an awful lot with telehealth programs when they come to us and ask questions is what are the challenges that are likely to face, and how do you overcome those? And again, these get very, very idiosyncratic depending on who your providers are, what your platform is, what kind of service you're providing. And so I can't say a whole lot specifically, but I can say that over time we've found a number of issues come up, categories of issues come up, and the number one category is generating value. A telehealth program might seem obvious. It's like, of course we need this because we need mental health services. But as part of that planning process, you need to figure out how are these services going to get paid for. Usually, they're going to be paid for the same way that other services. You're providing medical care, you're providing health care, behavioral health care. You bill the patient's provider, or the patient's payer, insurance company, sponsor. You bill them the same way for a telemedicine encounter as for an in-person encounter. Usually that's the way you monetize it. But there are other ways too. And sometimes you're going to provide a service that isn't directly billable. And so you just need to make sure and take a look at that. And again, to get down into the weeds, we can follow up with you to help you understand what exactly is the payer matrix you're dealing with, which payers are going to pay and how much. and we can help you through that process. The second problem that organizations find is what I would call generating internal interest. It's like you have a primary care clinic, and now suddenly a telebehavioral health service is available, and those primary care providers need to start referring people into the telebehavioral health provider, whether it's a psychiatrist or a mental health clinician or somebody. And we just find that those providers don't refer as many people as they thought they would. And so there's just a lack of internal interest. Or now a cardiologist is available by video on Friday afternoons, and the service just doesn't get used. So it's important, and what we find is that it's important to have some sort of a default process by which people who meet a certain screening criteria are, in a sense, automatically directed into those programs, so that there is a steady stream of people, steady stream of patients that are referred into those programs. Because over time, what seems to be the case is that providers, when they don't have access to a psychiatrist or behavioral health or whatever, they just develop workarounds, and they end up continuing to use those workarounds rather than referring into the new service. So that's just something to be aware of when your program doesn't take off the way it seems it should. Lastly, technical issues or policy issues that are inflexible or misunderstood. Usually a program doesn't stand or fall based on the technology. Usually technology problems are solvable in some way. But they can be issues, they can come up, and most often it's not that the technology can't work, it's that technology decisions were made without the right information, and now we're locked into a certain technology that can't do what we want. And so the only fix for that, if you're down that road already, is to take a real hard look at the technology you have and what it can do and what are the cost benefits of sticking with it. The better fix, of course, is to not go down that road, to figure out how to get the information you need up front and talk to people who can see down the road a ways. And of course, tomorrow's technology is always going to be better and more flexible and easier and cheaper than yesterday's technology. And so that's just part of healthcare, part of business generally. So the more you can predict what you're going to need and recognize what sorts of products are becoming available. For example, web-based video and web-based telemedicine is way more flexible and way less expensive now. But 10 years ago, when we were getting programs to be early adopters of telemedicine, that just wasn't the case. And so there's no way they could have foreseen that. But organizations now who did adopt early are at the point of asking questions: do we stick with these cart-based solutions or these hardware-based solutions that we have that are working, but are now performance-wise totally eclipsed by software-based solutions that are available to us today for a lot less money? So those questions come up, and there's no silver bullet there. The point I want to make here at the bottom is that these are management issues and healthcare issues and even just business and technology issues, not necessarily telehealth issues. Telehealth didn't invent the problem that technology is always moving fast and we have to stay ahead of it. It's just that that problem really comes out in developing a telehealth service or a telehealth program. So I do that. I guess I say that partly in defense of telehealth, that we didn't invent these problems, but also to recognize that the same problem-solving skills and resources that you have in general for your clinic or for your hospital or whoever are the same kinds of skills and organizational approach that you're going to need to solve these telehealth programs. If you're a lean Six Sigma shop and you've got processes in place for improving quality in your other areas, well, apply that to your telehealth program and figure out what you need to solve a problem. It's not a foreign concept. I can spend a fair bit of time. So for the rest of the time, I'm talking about I'll talk about business models, but more kind of billing models. And the fundamental point here is that, again, like I said, telehealth is not one thing. Telehealth reimbursement is not just one thing. There are multiple streams of reimbursement, just like in your regular healthcare. You have multiple payers, but also you can structure telehealth programs in multiple ways to to target sources of revenue that only apply in certain models, in certain programs. So I'll talk about the kind of standard model of telehealth first, but then I'm going to talk about some alternative models and collaborative care as an alternative model, as well as contracting as an alternative model. I'll say more about that. Just as ways that you can think about structuring your program so that you can access more access payments or access sources of revenue that are sort of sweet spots, if you will, in the telehealth world. So first, Medicare. Medicare is kind of the big, well, it's a big player historically and has a lot of mind share in the world of telehealth. The great thing about Medicare is that they publish a booklet that summarizes everything they do. They have a website where you can look up whether you're rural or not, because the number one or one of the most salient characteristics of the Medicare telemedicine program is that the patient has to be in a facility or at an office, a healthcare facility of some kind that is in a rural area. Medicare is not going to pay a professional fee to the doctor unless the patient is in a rural area, except for a few exceptions that I'll talk about. And so they have a way that you can look that up, a website where you can look that up. They also will give you these CPT codes are what we pay, and it's very straightforward. They list it right there in the document, so you know exactly what Medicare is going to pay for. You bill that code with the right place of service code, O2, meaning the place of service. Telemedicine. Telemedicine is a place of service, kind of a conceptual place. But when you bill with that code O2, then Medicare knows that you're claiming telemedicine on that encounter, and you're attesting to the fact that the patient's in a rural area, or at least that the patient complies with the requirement. The originating site where the patient is, of course, can bill an originating site fee. It's also Part B. It's not a facility fee like other facility fees that are Part A. It's a Part B facility fee, but it's billable by the originating site, the patient site, with a Q3014 code, and that's all that code refers to is telemedicine originating site. The one thing to notice about this is that CMS conceptually understands telehealth as happening between two different legal entities, a clinic or a doctor's office or somewhere where the patient is that bills that originating site fee, and another office where the provider is that bills that professional fee, that those are two separate entities. And this explains a lot of the sort of inflexibility that you get with Medicare and telemedicine. The patient and that originating site needs to be in a rural area, and it needs to be separate than the provider who's billing the fee. Unfortunately, that model isn't always used presently. I call that original model, that Medicare model, referring out to telemental health, so that the providers at some other organization, they're billing their own professional fees. And so from the perspective of the clinic that has the patient, where the patient is, we refer out to those mental health providers. The patient gets scheduled for the telemedicine clinic with Dr. X, and the patient sees that remote provider. And then that remote provider actually is the provider of record. Their EMR is what is the official record of that encounter. They do the billing to the payer or whoever. They get the copay, except the patient is there in your office trying to do their copay, but they really owe the copay to that other provider, not yours. So it's complex that way. The local clinic gets a copy of those notes and has to be sure that, there was a patient on your site seeing a provider. You need to have a record of that encounter. And so you have to get the records from that other provider, and you might have to make some records of your own. And you can bill separately that facility fee, but the pro fee and the copay you don't have access to. That's what I call a referring out model for telemental health, or any specialty the same way. That other clinic is actually seeing the patient, and you're just a site where the patient has come in to connect with that other clinic. But most telehealth, as I was alluding to earlier, is not that anymore. It's not structured that way. There's still some, and I'm not saying that you can't do that by any means. I mean, all of Medicare telehealth is structured that way in some sense. But most telehealth anymore is structured differently. most often internal resources from an organization are redeployed to another location. So for example, a health center has a provider, a psychiatrist at one site, but they have multiple other sites 50 miles away, and the provider could drive out there and do clinics on some days, but instead they're going to send the provider virtually to those clinics and do a telehealth program where their pediatrician or their child psychiatrist or their psychiatrist or their mental health provider, whoever, is going to see patients by video at those remote sites. That's the most common model of telehealth anymore. Other models include some kind of value generation using electronic telecommunications that isn't directly billable. It avoids a penalty of some kind, like a readmission penalty, or it reduces costs like travel, like provider travel costs, mileage, and time lost. And sometimes it's engaging external providers under contract. So you need a psychiatrist in your clinic, you contract with somebody to see your patients 6 hours a week, and then on Thursday mornings and Tuesday afternoons, they're available under contract, you pay them by the hour, and they reassign benefits to you and you bill it out of your clinic. Those kinds of models are more common now than the original Medicare model. And for multiple reasons, and I won't go into those, but there are reasons why the other model has a harder time being sustained often. So what happens here is that instead of the provider at their site and the patient at their site, we have the provider sort of virtually entering the clinic. So the provider becomes a virtual component of the local clinic, and then the local clinic bills that encounter out of their own business, out of their own four walls, out of their own entity, with the provider as their contracted provider who has reassigned benefits to the local clinic. This is a very common arrangement. It's just that now we're adding the virtualized component. And so that provider, in a sense, instead of driving into the clinic to see patients, they're telecommuting in. And sometimes we use that term, telecommuting into work to see patients. So what, and I know I'm spending a lot of time on this, but it's a somewhat new concept for a lot of organizations that are thinking about telemedicine, and they're reading through the Medicare regulations because it's a nice summary of telemedicine, and they're not understanding how those regulations apply to their situation, or they're wondering why this clinic does it a different way. I'm saying that this model is now becoming very, very popular. And it really does change who owns the patient, whose patient it is. Because in that first model, the local clinic was basically sending the patient virtually to the provider's clinic. Clinic A was sending the patient to the provider clinic at Clinic B, and then that provider was seeing the patient and billing the patient and doing everything that they do. Whereas in the new model, we're really bringing the provider into the clinic patient, into the clinic site. We're contracting in that provider and then saying, okay, we're going to provide services out of the clinic, the virtualized provider, but we're going to do that out of the clinic, and then we're going to bill for that out of the clinic. The most obvious application of this is FQHCs that get an enhanced encounter rate, a PPS rate, for seeing patients on site, their patients on site in their location with their provider. And if they can make that virtual provider one of their providers, then it's their provider, their patient, their site, meets all the requirements for billing an encounter rate. And so they do that. And in that sort of arrangement, the provider's location, their actual physical location, really is irrelevant. It doesn't matter. Wherever they are, they're working for the clinic at the time of the encounter, under contract and with their reassignment of benefits. So that's what I call contracting in, as opposed to referring out through telemedicine. And it's a mind shift, a mental shift, conceptual shift that is challenging sometimes, but let me talk a little bit about some of the benefits. The first benefit we've talked a little bit about, and that is that it brings the resources into the clinic. Excuse me. It brings the pro fee, the provider fee, the bulk of the money for healthcare that goes to the provider, it brings it into the clinic so that the clinic has control over that. If it's a PPS rate, it's an enhanced rate, then the clinic can use that money to contract with a provider. And the clinic can do the scheduling of the patients. The clinic can work with a provider on availability. We would like you to see patients on Tuesday afternoons and Wednesday mornings. Under contract, you can do that. Whereas when you're referring out to a provider by telemedicine, you might have an LOA and you might make arrangements, but ultimately that provider's kind of deciding when they're going to run their clinic and how that procedure is going to work and when they're available and all of that. So the contracting in brings the control of the situation much more to the local clinic. All of the same services can be provided, but when you're contracting in that provider, you're also usually having them, well, you are, since they're your provider and they're reassigning benefits and you're contracting with them, you're expecting them as part of that contract to work in your EMR. And so the records become available in your EMR. When they see the patient, they're documenting in your EMR. And that means that your primary care docs, when they want to know what happened when I sent this patient to the behavioral health clinician, they can look it up in their EMR just the same way they can look up notes of any other provider in the clinic when they need to coordinate care. And so the coordination of benefits are huge, are tremendous, because those providers can now see. And they can message. If you do messaging within your EMR, they can message that behavioral health provider. Likewise, behavioral health provider can message the doctor. And so that communication, that integration of services is much closer to a co-located and in fact fully integrated behavioral health service than just having a provider who's available virtually on site, but who we send patients virtually to, and then they document and do everything kind of independently of us and send us a copy, fax us a copy at the end of it. So we're really talking about implementing a much better integrated service, even though virtually we're separating, geographically we're separating, but from the perspective of how it's contracted and where the provider notes end up and where it legally exists, we're having a much tighter integration. And of course, I just made all of my points here that I have on this slide, that the provider works for you, that you control when they're available. You're motivated to fill those clinics and no-shows. No-shows, of course, are a huge challenge regardless of where you're serving patients, but the remote provider is never going to be that well connected with patients to be able to fill no-shows and backfill and do all of that kind of local legwork that the local clinic is. And so although you're taking on the risk of no-shows, you're also increasing your control over who shows up, and when somebody cancels, who can we call to get into that slot? And you have that ability to do that. All the registration, the billing, the co-pays, all of that stays local, and that's a benefit of simplification, and all the notes end up in your EMR. I will just say a couple of words about collaborative care, and then we'll have some time for Q&A. The whole idea of collaborative care, and collaborative care, there's sometimes some terminology issues I have to be clear about. Chronic disease management is sort of a model, and chronic care management, CCM, is a specific billing type. I'm using it as a specific billing type within Medicare for managing chronic diseases. And then a type of chronic care management that's really a kind of a separate category for Medicare is called collaborative care management, COCM, usually, collaborative care management, which is the behavioral health version of CCM. For treating patients with mental health conditions, we'll often talk about a collaborative care management versus for COPD or diabetes or asthma, we're going to do a CCM model, whereas for mental health, we'll do a COCM model. So they're analogs, they're very similar, but COCM, collaborative care management, specifically focused on behavioral health, mental health care. So, and conceptually, what we're talking about here is this idea that primary care clinics, of course, exist in the community, and for many people with no mental health need or minimal mental health need, the primary care clinic is entirely adequate. They can go in, see their doctor. Hey, I'm feeling a little down, feeling a little depressed. They can get a diagnosis and a first-line antidepressant, or they can work at it for a while, get some psychotherapy locally or whatever. That can happen at the health center, at the community health center or the primary care center or whatever, at a primary care point of care. We also have in our communities mental health centers that deal with the severely mentally ill and provide inpatient services and specialized services for those who are disabled by mental health conditions. And in fact, they also have slightly less intense services where they have providers that or community-based folks who go out into the community to support folks with mental health conditions, with chronic, long-term, severe, debilitating mental health conditions, but help them to stay housed and manage money and stay functional in the community. And mental health centers have, it's a whole side of their business to support, have community-based support services for folks to maintain their lives despite their conditions, despite their mental health challenges. And that is a planned, proactive, scheduled service where people go out and periodically meet with folks to provide that supportive care. So somewhere between those, though, there's a group of patients that is a little more severe than just intermittent, mild and moderate needs at the primary care level, but they're not severe enough to need inpatient care or even the intensive supportive services of the mental health community or the mental health center. But they could use some scheduled, proactive, structured care with treatment toward a criterion that is objectively evaluated. They could use that level of care that the primary care office, at least before the advent of chronic care management types of services and population health types of services, we really weren't thinking about that in primary care. But now we are. And so that group of patients in the middle has had a care gap that is now being filled by this collaborative care model, at least in the mental health world. In the medical world, we're filling it with a chronic care management model, same kind of a thing. And so that collaborative care model implies structured care, outreach-based care, where it's proactive, where we're scheduled to meet with the patient and say, okay, how are those meds working? Let's do a med reconciliation. Do you still have the right? Are you up to date on those? You're going to need a refill next week. How are you going to handle that? Do you need to see the doctor? What are the side effects? And do we need to look at changing your medications? All of that gets handled proactively on a schedule. We don't wait for the patient to show up and say, boy, things are going wrong. We reach out before that happens and we make that work. In that collaborative care model, again, it mirrors the chronic care management model in that there is a point person on the team, in this case a behavioral health care manager, that yellow person in the middle, whose responsibility is for primary contact with the patient, primary and regular and planned contact, weekly contact with the patient to find out how they're doing and what needs to happen and to provide support. They are also conferencing with the primary care provider to let the provider know how the patient's doing and give them updates, summarize. They don't need the whole story. They don't need a whole rundown or a whole history. Here's what happened with Joe this week, but Joe's doing fine, no updates this week. Or Joe's not doing so well. I'm getting him in to see the psychiatrist, or I'm going to run this by the psychiatrist and we're going to see about changing his meds so that people are up to date. Likewise, the behavioral health care manager is conferencing and doing case reviews with a psychiatric consultant, a psychiatrist or a psychiatric nurse practitioner who can prescribe. And then that person is providing recommended treatments that then the primary care doctor is prescribing. And so this whole team works together, and it minimizes the need for minimizes the time need on the part of the psychiatrist and also on the part of the primary care doc, and it invests that time, the time-based services in that behavioral health care manager, contacting the patient and checking in with them. So an example of a call, the behavioral health care manager might say, hey, let's review your rating scale for this week that I saw you went online and filled in, or let me just ask you the questions and you can respond to them. How you feeling? What's your mood? How was your sleep? Et cetera, et cetera. Let's review your meds and reconcile those again. Let's check about response to side effects. How's your mood? Sleeping okay? How about those dreams? What's going on with that? Your appetite, dry mouth, whatever your side effects might be, and is it bad enough that we need to talk to the doctor? Okay, now you had wanted to apply for some jobs. How many calls have you made? You provide this behavioral activation, level of support in the call, make some notes about that, any changes to your housing or your job, other issues that might, social determinants, types of issues that might impact outcome and response to treatment. And then, what's our next call? Okay, well, I'll call you next Thursday again. And in the meantime, I'll talk with your doctor and update them, and we'll be back in touch. And so you have these kinds of multiple little lightweight touches by this care manager, behavioral health care manager, and they might be doing that most days of the week. They might be seeing patients, not the same patient, but other patients. They might manage a whole group of patients by making calls, most days of the week. And then once a week, they're going to sit down with a PCP and they're going to, okay, I'm going to run through the 25 patients that we're working on in the program right now. Last week, we talked about the first 10. So this week, we're going to talk about the second 10. And you run down each of those and how they're doing. And it provides, and then you do the same thing with the psychiatrist when you sit down with them. Okay, we talked about the first 10 patients last week. Let me update you on the second 10, or anybody who's got red flags this week, or urgent things that have come up. And so the care manager schedules their time around patient contact, and then some time to coordinate with each of the specialized providers once a week, so that some subset of patients gets reviewed every week with each provider, and all patients get a review at least once a month. And then all of that time gets logged as care management, and it gets reimbursed at a monthly rate rather than a per encounter rate. There's also a lightweight version of this that doesn't even involve a psychiatric care manager. It's just the primary care provider providing a few, 20 extra minutes every month of review of the case, or some team member. It doesn't even have to be the primary care provider. Some member of the team has called the patient, has reviewed an online form that they filled out, a weekly form, or they've done some sort of service on behalf of the patient, some sort of provided some sort of care as part of the team, and then that primary care provider can bill that as a 20-minute encounter, or 20 minutes worth of care management on the patient's behalf. I will stop there with collaborative care management. I'll give you the short answer in that it is very structured, and it requires a pretty heavy lift on the part of clinics. But because of one of the key things that collaborative care management does in the world of telecommunications is that it really turns you loose to contact and interact with the patient via any channel you want. If you want to do live video encounters, if you want to do telephone, if you want to do some kind of secure texting, all of that is possible. All of that is on the table. And you don't have to worry about billing each encounter, each text, each update, because it's billed as at a monthly rate. And this is why I think in the future, those kinds of monthly care management models are going to be more popular, along with the fact that it provides so much more flexibility. And ultimately, we're managing mental health conditions as chronic conditions most of the time anyway. And patients can move into more severe, more acute kind of phases, and then they move into less severe kind of management, and maybe we lose touch for a while, but then they come back when things get worse. And that happens throughout the lifespan. And so we're treating mental health conditions much more along that model, and a chronic care kind of a model. So that's why I see those programs as beneficial in the future, as of course as Medicaid learns to cover them. Right now Medicare does, but Medicaid in most states doesn't, and it varies from state to state. So in summary, I think that these services, it's great to integrate them. I think it's obviously you all know that, would love to do that. The regulations they mirror in-person care in a lot of ways, and we just need to recognize how to apply them in that way. They can be implemented as direct services, but also in a sort of a monthly collaborative care model, as I was saying. And FQHCs and RHCs, as always, are kind of their own subset, and of course are reliant on Medicaid coverage for a large percentage, if not the majority, of their funding. So I need to recognize that specific funding and how that's going to cover virtualized services, telehealth services of various kinds. that is all for today. So I'm going to stop my share and we'll take a look at the Q&A and see what we can answer before the end of the hour here.
Thank you so much, Jonathan. Always a wealth of information. There's one question so far. You need me to read it, or?
I can see it now. Are you seeing a lot of organizations implementing telebehavioral health consults in the ED? I can answer that one verbally rather than typing. And yeah, it is one of the, I think it's one of the most commonly mentioned applications of telebehavioral health. In part because, you know, hospitals and hospital emergency departments have a lot of say when things are going wrong in the ED. You know, they can raise the issue and they can get attention. Plus, it's a site and a place. It's a place and a time that it's a very clearly defined problem. And so yes, you can do that. You can do it with psychiatry. You can do it with other social workers who do evaluations in the ED. And often, what folks are doing is hosting that service at the mental health center, or sometimes a centralized location. But the idea is that when a patient comes into the ED, the end result of that encounter is going to be either reconnecting with a mental health provider of some kind, or a disposition to an inpatient facility of some kind. And so when you host that evaluation in the inpatient facility, you can often facilitate that disposition to inpatient. And there are various ways to structure that. But so often it's hosting a clinician from the mental health center virtually in the ED to see the patient, do the evaluation, and then start the inpatient transfer process to the mental health center. There are other ways to structure it, of course, but telebehavioral health in the ED is by far one of the, it's definitely in that top tier of behavioral health implementations that people are thinking about and implementing.
Next question is about slides. Would you be willing to send me the slides so I can send them out?
You bet. You bet. Always happy to do that.
Any other questions? All right.
Looks like we covered it.
All right. Well, thank you very much, Jonathan. I appreciate it. And if you guys are interested in, if anyone, I didn't really pay too much attention to the RSVP list today, but the National Telehealth, National Consortium of Telehealth Resource Centers has been doing a special FQHC webinar series. There's 2 of them that are archived on the national website. I will send that out to all registrants as well. And then there's going to be another one coming up in August.
Yep. Yeah, very helpful. We're focusing a little more intensely than we have in the past on